So, good morning, everybody. Today I would like to present my progress in my PhD topic about the complex physiotherapeutic evaluation of COVID-19-associated multisystem inflammatory syndrome, or shortly MISC. My name is Adrienn Lukács, and I'm a junior investigator in the program of Translational medicine. I'm a physiotherapist, and during the next years, my mission is to improve the pediatric physiotherapeutic care. To reach this goal with my researches, I would like to provide scientific and profession-specific information. We conducted 3 different studies to focus on the main aspects of this disease, and the first one is about the prevalence and characteristics of different cardiovascular abnormalities. 3 to 6 weeks after COVID-19 infection, multisystem inflammatory syndrome can occur. One of the biggest problems with this disease is that more than 75% of these children can experience some kind of cardiovascular problem during their disease course. Luckily, in most cases, these changes are normalized at discharge, but sometimes they can remain and become long-term morbidities. As a physiotherapist, it is really important to know if we should expect any kind of cardiovascular problem or not, because it can influence the whole rehabilitation process. We are looking for those children and adolescents who are under the age of 21 and fulfill the MISC criteria. We conducted a systematic search with the search key and got an overall 114 eligible articles. We have several outcomes and results, including radiological and laboratory findings, and also intensive therapy needs. Therefore, today I would like to show you the 3 most important ones. The first one is about the incidence of coronary artery aneurysm, which is an uncommon condition among this population and means the abnormal dilatation of a part of the coronary arteries. We included 5 articles which use the American Heart Association's Z-score classification. And after investigating more than 200 patients, around 11% of these children experience changes in the size of their coronary arteries. For comparison, you can see the Kawasaki disease rates, which is twice higher than our results. Therefore, it means we can suggest that MISC children tend to have a lower risk for coronary artery involvement. However, this is a serious complication, and we need to pay attention for this. With the second outcome, we investigated the occurrence rate of the left ventricular dysfunction. We used the term called ejection fraction, which represents the amount of blood being pumped out by the left ventricle with each contraction, and we expressed it in percentage. It's normally between 50 to 70%, and the cut point of 35% represents the severe and moderate dysfunction of the left ventricle. After investigating, again, more than 200 patients, around 7% of these children experienced severe heart failure and myocardial dysfunction during their hospitalization. And our last outcome is the incidence of ICU admission. We included several articles with a relatively high heterogeneity, and from more than 4,000 patients, around 45.8% of them needed an ICU admission and an intensive therapeutic level of hospital care. For comparison, it's 10 times higher than in case of pediatric COVID-19 disease. This suggests us a more severe disease course in case of MISC. Covering the most important parts of the disease spectrum is one of the biggest strengths of our study. Also, we were able to form and analyze ICU subgroups, and we used objective criteria for the left ventricular dysfunction and coronary artery abnormalities. We have some limitations too. We had to include different types of articles, and the articles used a variation of case definitions for diagnosing MISC. And one of our biggest limitations is that these papers are from the first and second wave of COVID-19 pandemic. Therefore, we can show and highlight the consequences of only certain variants. As an overall conclusion, MISC children can present a broad range of cardiac findings, and based on our results, the most common ones are the valvular regurgitations, the reduced ejection fraction, and myocarditis. Our findings are agree with the ACR's guideline and confirm the need of cardiac assessment. And there is also a need for an extended multidisciplinary approach to involve physiotherapists to the healthcare if it's possible. As an implication for practice, we recommend early cardiology consultation, regular echocardiography examination if there is a left ventricular dysfunction, and physiotherapeutic assessment can be useful for these patients. And also, due to the high number of asymptomatic COVID-19 cases, proper public information is crucial for healthcare professionals and caregivers too. As an implication for practice, we need an international registry to collect more data and some further investigations to find more associations. We finished with the article draft sent to our SMS, and we would like to send to internal review as soon as possible. And our targeted journal is the JAMA Pediatrics. Our second study is a cohort analysis of 29 previously MIS-C diagnosed children. As we saw, a high rate of these children need an ICU admission, and we also know the side effects of mechanical ventilation and the bedridden periods. And there is also the so-called pediatric post-intensive care syndrome, which can commonly occur in patients after the ICU discharge. Therefore, we would like to compare those children's physical performance who were 12 months prior diagnosed and cured with MIS-C using functional tests with validated reference ranges. We included those children who were hospitalized in the Hungarian National Pediatric Institute and got the diagnosis of MIS-C based on the WHO guideline. I have some preliminary data which I would like to show you from the first 29 patients who had a physiotherapy assessment at the 12 months time point. The median age was 11 years old with a slight male dominance. Also, 55% of the children needed an ICU admission. Almost everybody got an IVIG therapy, and more than 80% of the children needed steroids too. We asked the caregivers and the patients to estimate the time period which was needed to feel healthy again. More than 40% of these children needed a month or less. But unfortunately, around 30% of them still experiences some problems related to MIS-C. Mainly, this is fatigue in 6 cases, or headaches, and some other. Our last study is an international multi-center survey about the practice and experience level of physiotherapists during the COVID-19 and the MIS-C. Currently, we still don't have a worldwide known and accepted physiotherapeutic guideline to treat these children, so our aim is to identify the similarities and the discrepancies among hospitals internationally and see what the others do and why. We prepared our questionnaire. It has 3 question groups. The first one is about the standard baseline data, like educational data or the type of the work field. The second one is the knowledge about the symptoms, guidelines, possible treatment options, and experience level. And the last one is the physiotherapeutic care. This is the most practical one, like the time point of the first visit, the frequency and duration of the visits, or any follow-up options. The PRC team revised our questionnaire in the beginning of December, and we find some potential experts in this field, and now we are organizing a meeting with these international experts to start a collaboration with them. So this is a quick overview of our studies, and with the results of our studies, our aim is to find the answers for the questions, the when and how questions, how a physiotherapist help to these children, and to standardize our physiotherapeutic treatment. Thank you for your attention, and please feel free to ask questions if you have any. The man who moves the mountains begins by carrying away small stones. It's from Confucius.
Thank you. I have a question regarding your second project. What is your experience or impression about your cohort, and compared to the international ones, are there any differences in the therapy or severity? What is your impression with that?
Thank you very much for your question. As an overall impression, our cohort was quite similar to the international reports, but mainly with possible less severe disease course. We previously talked through this issue with the hospital's cardiologist, and our final conclusion was that the early initiation and the high rates of using IVIG therapy could be a possible explanation for a modified disease course. And the international treatment guidelines also highlight the use of IVIG and also the combination of IVIG and corticosteroids as a first-line therapy. So this can be the possible explanation, the high rates of IVIG initiated early as a local practice.
My question is regarding your second project as well. These remaining symptoms like fatigue, is there a protocol or a treatment that we can use to reduce or decrease the fatigue?
Thank you, your question. It's an excellent question, and it's a quite complex topic. As a physiotherapist, we have some recommendations to treat these patients, and the main points or weak points for this therapy is like determining the baseline activity level of these children and any confounding factors like sleeping routine or school schedule or screen time. And if we are finished with assessing all the confounding factors and all the baseline level, then we can plan a specific exercise. And we also sometimes encourage them to involve high-quality relaxation time and self-administered relaxation techniques. And if remission occurring, then we also highlight that to contain the physical exercise, just step one back and from a lower exercise level.
If I remember well, you applied the Z-score system. Can you explain a little bit more why?
Yes, it was about the coronary artery aneurysm size. Kawasaki disease is one of the closest disease for MISC, and as a base point, researchers started using the American Heart Association's Kawasaki guideline, and it has a cardiovascular chapter, how to measure it, how to analyze it, and the guidelines recommend using the Z-score classification system because it can give you an objective categories for these measurements, and that's the reason we follow the international practice.
Just a quick, rather maybe a comment to the previous discussion with the fatigue. Could it be like, do you explore if it's more a motivational problem, or is it really a physical problem? Are there any psychologists maybe involved? Where do you go with this?
Yes, this is a very good question and a very good recommendation. It's up on a big part of a motivational part, and yes, some mental and psychology provision would be very good for these children.
Do you monitor it in your study by any chance? Like, are you planning on checking whether it's a motivational one or is the physical symptom any questionnaire maybe?
Until this point, we haven't, but we will consider it to involve to our study. Thank you.